You have already finished microbiology. Why is the virus called cytomegalo? What? That is the characteristic cytopathic effect of the virus. It can cause enlargement of the infected cell. And this is the characteristic appearance of a cell infected by a cytomegalovirus. So the cell size will become increased. So compare the size of that cell with the rest of the cells present in that field. And then the size of the nucleus is also markedly increased. And then what can you comment about the organelle pointed? How do you call that organelle? It is inside the nucleus. It should be the nucleolus. So notice the red-orange appearance of the nucleolus, and then it has also become markedly enlarged. So that enlargement is due to the presence of the viral particles. Okay, so viral particles will impart that characteristic, or specifically, the viruses are called the viral inclusions. Okay, viral inclusions will produce red to orange discoloration of the contents of the nucleus. So you will be able to get the diagnosis by being able to identify that enlarged cell with characteristic intranuclear viral inclusions. Intranuclear viral inclusions with characteristic enlargement of the infected cells. And then the rest of the lungs will show mononuclear or polymorphonuclear inflammatory response. Mononuclear. Where will you be able to see polymorphonuclear inflammatory response? In what type of infections? Bacterial infections. So that is why you're able to see round-shaped nuclei of the inflammatory cells. So they can be, majority of them are the CD4 and the CD8 lymphocytes. Expectedly, what will kill the cells which are infected by the cytomegalovirus? CD8, via releasing what two classes of chemicals? Perforins and fast ligand and granzymes. Fast ligand and granzymes can cause what effect to the cell infected by the virus? What? Very good. Apoptosis. So expect that this slide, if ever it comes out in a practical exam, will be under high power magnification for you to be able to see the characteristic enlargement of the infected cell and the eosinophilic, or the pink to orange colored viral intranuclear inclusions. What is the abnormality that you can identify in that field? Hemorrhage. Very good. Hemorrhage or bleeding. So the alveolar spaces are occupied by extravasated red blood cells. And then identify the cell pointed. How do you call that cell? Okay, hemosiderin-laden macrophages. So it is a macrophage which has phagocytose the extravasated red blood cells, because the red blood cells are not supposed to be seen inside the alveolar spaces. They should be inside the blood vessels in the interstitium of the alveoli. What is the diagnosis for slide number 10? Lung. Oh, bakit may hemorrhage ito? Anyway, the stain that is used for this slide is hematoxylin and eosine. Usually, that set of stain will not be able to demonstrate fungal elements. So that we will not have this slide for the practical exam. Okay, for this lang, what can you comment about the alveolar spaces? The appearance of the alveolar spaces. What are the materials present, or the cells present in the alveolar spaces? Red blood cells. Aside from the red blood cells, you're able to see golden brown pigments. What other cells present in the alveolar spaces? What will phagocytose the extravasated red blood cells? Okay, the alveolar macrophages. Can you please check for the diagnosis of slide number 28? Good pastures. Good pastures affects primarily what organ or what tissue? The basement membrane of the alveolar spaces. Aside from the respiratory tract, what other organ is affected? The kidney. So good pastures is a form of what type of disease? Autoimmune. Hypersensitivity reaction affecting primarily tissues of the alveoli or the blood vessels? The blood vessels. So, we are able to see hemorrhage in this lung because of the destruction of the wall of the blood vessels. Basically, we should be able to see inflammation in the wall of the blood vessels. Okay, so that is a blood vessel. Good pastures is described as necrotizing vasculitis. So we should be able to see infiltrates of neutrophils with areas of necrosis in the wall of the blood vessels. Let us look for a character. For a blood vessel which will demonstrate necrotizing vasculitis. Fortunately, almost all the blood vessels present in this slide do not show the characteristic vasculitis, inflammation. Anyway, that blood vessel shows us infiltrates of neutrophils in its wall. However, we cannot specifically designate that infiltration of neutrophils as good pastures. Okay? So that microscopic abnormality can be seen in other forms of vasculitis also. So it will not be reliable if we come up with a diagnosis of good pastures for this slide. Dapat vasculitis lang. So because of that confusion, again, one slide down. It is abnormality that you can identify in that field. Hemorrhage, massive hemorrhage. And then, can you still identify the wall of the alveoli? No. Wall of the alveoli is not anymore identifiable. Okay, so parang pink shadow na lang ang naiwan sa wall ng alveoli. Usually, what is the epithelium lining the alveolar spaces? Simple squamous. So in between the two simple squamous epithelium, you should be able to see capillaries, which are also lined by simple squamous epithelium. Are you still able to identify the squamous epithelial lining of the alveolar spaces? No. So basically, how will you describe that portion pointed? Are you able to see any nucleus? No. So that pointed portion should be diagnosed as having, what is the abnormality in that pointed area? Absence of nucleus will indicate that the cells are necrosis, necrotic. So this is a necrotic portion. And because the wall of the alveoli, which contains the capillaries, become necrotic, the blood vessels rupture. Blood vessels rupture, leading into the escape of the red blood cells into the alveolar spaces. They will become accumulated in the alveolar spaces. So we are able to see evidence of necrosis or infarction. So slide number 31, anong diagnosis? Okay, acute infarction. Red infarct or white infarct? Red. Why red? Why will the lungs develop red infarction? Dual blood supply, aside from that characteristic? Soft tissue. What do you mean by infarction? Necrosis because of loss or obstruction to blood supply. You should be able to already identify the type of necrosis shown. What type of necrosis is that? Caseous necrosis. So, slide number 36, please. TB. Okay. What type of inflammation is involved in tuberculosis? Type 4 or granulomatous? Type 4 or granulomatous? Type 4 is a classification of the hypersensitivity reaction. We should be able to see granulomatous inflammation in tuberculosis. However, the cause of the underlying mechanism behind the development of the granulomatous inflammation is type 4 hypersensitivity reaction. How do you define granulomatous inflammation? It is an inflammation which is characterized by the infiltration of particularly what type of macrophages? Activated macrophages or the epithelioid macrophages. Now, activated, or more commonly they are called epithelioid macrophages. Okay, normally that is the appearance of the macrophages. Okay? That is the appearance of a regular macrophage and a lymphocyte. Okay? That pointed cell is a lymphocyte, and then that cell pointed is a regular macrophage. When the macrophages become activated, they will assume that appearance. Okay? Much larger than the regular macrophages, and then they will look like squamous cells. That's the name epithelioid cells, or epithelioid cells. Epithelial-like looking, epithelial cell-like looking macrophages, because they will become enlarged when they become activated. So the activation will cause enlargement so that the macrophages will become more efficient killers, more efficient phagocytic cells. Now, Can you still remember in type 4 hypersensitivity reaction, what causes? What will inform? What cell will command the macrophages to become activated? Particularly what population or what class of T lymphocytes? CD4 lymphocytes. That is why we are seeing lymphocytes among the epithelioid cells, because they are the ones which will release the cytokines, transforming growth factor and tumor necrosis factor to the macrophages to become, for the macrophages to become activated. Now, how do you call the abnormality pointed? Necrosis. What will cause the development of necrosis in tuberculosis? Will it be the effect of the TB bacilli themselves? No. What will cause the development of the necrosis? Aside from CD4 lymphocytes, what other population of lymphocytes will you be able to see in type 4 hypersensitivity reaction? CD8. Okay, CD8. Now, what is the action of the CD8 lymphocytes? Kill infected cells. What are the cells infected in tuberculosis? Tapos na kayo sa microbiology, first semester. Parang lecture yan ni Dr. Simon. What cells are infected? What cells are infected in tuberculosis? Epithelial cells of the alveoli? When the TB bacilli reach the alveolar spaces, what cell of the immune system will meet them as the last line of defense? The alveolar macrophages. Now, unfortunately, during the first encounter of the macrophages with the TB bacilli, they do not have yet the enzymes that will allow them to digest what they have phagocytosed. The TB bacilli can actually multiply inside the phagosome of the macrophages. Aside from that, the virulence factor of the TB bacilli, one virulence factor, will also inhibit the fusion of the lysosome to the phagosome. Okay, hopefully you can still remember that specific virulence factor. Now, what will be the response of the macrophages when they are not able to kill what they have phagocytosed? Present the antigen. Present the antigen to the CD4 lymphocytes, which are the master regulator of the immune system, via what MHC? Class 2. 4 times 2 equals 8. And then, in response, the CD4 lymphocytes will release cytokines that will activate the macrophages, commanding the macrophages to produce the enzymes that will allow them to kill what they have phagocytosed. So that the macrophages are the cells infected by the TB bacilli. Now, what cells will undergo necrosis? Remember, you have CD4 and CD8 lymphocytes in type 4 hypersensitivity reaction. What is the other name for the CD8? What are the cells killed by cytotoxic T cells? Okay. Cells infected with intracellular microorganisms. In this case, the macrophages. So that the CD8 lymphocytes are the ones killing the macrophages. So if you will kill the macrophages, you will also kill the host of the TB bacilli, killing eventually the TB bacilli inside the macrophages to produce that type of necrosis. Because whenever the macrophages die, because of the effect of CD8 lymphocytes, the contents of their lysosomes will become released to the extracellular space. Whatever digestive effects the lytic enzymes of the macrophages have, the reactive oxygen species of the macrophages in their lysosomes have, to the microorganism, same destructive effects will be produced to any cell of the body exposed to those mentioned chemicals of the macrophages. So that is why we are able to see caseous necrosis in TB, not because of the TB bacilli themselves, but because of the response of the immune system. So that is why tuberculosis is classified as a hypersensitivity reaction disease. So what will cause tissue injury and destruction is the response of the immune system. Kaya hypersensitivity reaction. Identify the cell pointed. Langhans type giant cell. Now, what is the basic purpose for the formation of, what cells compose the Langhans type giant cells? Okay, they are the activated macrophages. So the purpose for their formation into giant cell is to limit the spread of infection. That should be the characteristic morphology that you should be able to see in order to diagnose tuberculosis. Caseous necrosis surrounded by granulomatous inflammation. Can you please check for the diagnosis of slide number 40? Okay. What's the difference between bronchopneumonia and lobar pneumonia? Consolidations are seen in morphologically, what is the difference between lobar pneumonia and bronchopneumonia? Now, unfortunately, the stain for this slide is very faint already. That's a bronchiole. Okay, that's a bronchiole. Notice that its wall is dirty looking. Okay, that dirty looking appearance is because its wall is already infiltrated by neutrophils. So if you are able to see neutrophils in the wall of an airway, what should be your diagnosis? Acute or chronic? Acute bronchitis or acute bronchiolitis. Now, unfortunately for this lung, some of the alveolar spaces immediately surrounding the inflamed bronchiole is also infiltrated by neutrophils, so that you have neutrophil infiltrations in the bronchus or in the bronchus and neutrophilic infiltrations in the alveolar spaces immediately surrounding the inflamed bronchus. So we are able to see inflammation developing in the wall of a bronchus and inside the alveolar spaces. In lobar pneumonia, where is the inflammation located? In the alveolar spaces only. Neutrophils are present in the alveolar spaces only. So, lobar pneumonia affects the alveolar spaces only, and then bronchopneumonia affects both the bronchus, the bronchioles, and the alveoli immediately surrounding the inflamed bronchus or bronchiole. So dapat mayroon kayong makitang bronchus or bronchiole which is infiltrated by neutrophils And then the surrounding alveolar spaces are also infiltrated by neutrophils. So, although they appear pink, those cells pointed are actually neutrophils. The red blood cells have brighter red color. Okay, so the stain in this slide is very faint already. Our next slide is a neoplasm. So what is the abnormality that you can identify in the pointed portions? Are you able to see any nucleus? No, so that the pointed area should be diagnosed as necrotic area. It should be labeled as a necrotic area because we are not able to see any nucleus. So what type of necrosis? Coagulative or liquefactive? Ayan ang mga cells. They lack nucleus. But still, we are able to appreciate the outlines of the cells. Liquefactive or coagulative? Coagulative. No. So dead cells, absence of nucleus. And then live cells or viable cells. Okay, those are the viable or the live tumor cells. And then those are the dead or the necrotic tumor cells. So the dead cells are characterized as having or by the absence of the nucleus. So such as the cells pointed. And then the cells below, okay, are prominently displaying their nucleus. Nuclei, indicating that they are still alive. How about those cells? Dead or alive? Dead. Okay. Now, this is the most aggressive neoplasm that will develop in the lungs. Its risk factor is smoking. So can you still remember the diagnosis for this neoplasm? Okay. So look at the size of the tumor cells. So their size is almost similar with the red blood cells. So they are small cells. That's the name small cell carcinoma. The old cell is the old name for the neoplasm. So we will be using the new name already, small cell carcinoma. Now, why is it that this neoplasm is characterized by viable and then large areas of necrosis? These cells are very aggressive. They multiply at a very fast rate. However, because of that activity, they also die at a very fast rate. That is why we are able to see large areas of necrosis. Can you still remember why tumor cells die? One, because of the action of the immune system. What is the main defense of our immune system against tumor cells? Natural killer cells and CD8 lymphocytes. However, in the case of small cell carcinoma, what should be the cause of the death of the numerous cancer cells? Okay. These cells multiply at a very fast rate. They have a very high turnover rate. There will come a time at which the rate by which the blood vessels deliver oxygen and nutrients to the newly produced cells will not be sufficient to the demand for oxygen and nutrients to the newly produced tumor cells. Thus, eventually, many of the tumor cells will die in malignancies with very high turnover rate. And then aside from having high turnover rate, this malignancy is also associated with very high metastatic rate. Most of the time, upon diagnosis, the cancer cells have metastasized already in the supraclavicular lymph nodes. So within 1 year, most patients eventually die. because of that aggressive characteristic of the tumor cells. What can you comment about the alveolar spaces in this lab? Are the spaces or are the alveolar spaces dirty looking or clean looking? Clean looking. Okay. What can you comment about the appearance of the interstitium? Thickened or thick. Thicker than the usual. So that increased thickness of the interstitium is because of the congestion of the capillaries in the interstitium and the infiltration of the mononuclear cells. Normally, there should be no inflammatory cell in the interstitium because the interstitium is supposed to be very thin to allow easy diffusion of gases. In this lung, okay, the inflammation is noted within the interstitium and not inside the alveolar spaces. So that we should diagnose this disease as interstitial pneumonia. Interstitial pneumonia. Slide number 62. Okay, interstitial pneumonia. Now, what are the two groups of microorganisms commonly causing interstitial pneumonia? Will this type of pneumonia develop in bacterial infections? Will this type of pneumonia develop in bacterial infection? Viral infection. Usually will produce interstitial pneumonia. So bacteria will cause bronchopneumonia or lobar pneumonia. Kaya neutrophils yung makikita natin sa lobar pneumonia and bronchopneumonia. So in the case of interstitial pneumonia, viruses and atypical bacteria. We have already finished microbiology. What are examples of atypical bacteria? What? Okay, Rickettsia. What else? Chlamydia. So those are examples of atypical bacteria. Hopefully you can still remember the reason why they are called atypical, not the usual type of bacteria. They lack organelles which are present in the common forms of bacteria. Oh, what is the abnormality in that field? Hemorrhage. What is the diagnosis for slide number 98, please? Histoplasmosis. Histoplasma capsulatum is a fungus. So to come up with the diagnosis of histoplasmosis, we should be able to see fungal elements.